Opinions expressed are those of the show hosts, not WSTU or Treasure Coast broadcasters. Any reproduction or reuse of this program without the written consent of WSTU is strictly prohibited. Welcome to Paradox. If you'd like to join the conversation, call 772-220-WSTU. And now your hosts for Paradox, Dr. Ira Pearlstein and Dr. Leanne Talton.
Warning, warning, Will Robinson, warning. Oh my gosh, Leanne, there are aliens in the OR.
I'm a little too young for this joke, but I hear ya.
Well, that's because today we have a very special guest talking about advances in robotic surgery. I'm going to introduce Dr. Adam Kurtin, renowned surgeon right here on the Treasure Coast.
Welcome to the show.
Oh, hi, good evening.
You weren't sure about that intro, renowned surgeon? Which was the wow?
I wasn't sure if I was supposed to say good morning or good evening. But
got it.
Good evening.
You know what's interesting, and I told Dr. Kurtin this before the show, and I hope, Leanne, that this isn't foretelling. He's a very accomplished surgeon. We've got all the Halloween decorations here, and he's sitting in front of tombstones overlooking a cemetery.
Thank you. Thanks.
I hope that's not your patient visits for tomorrow.
No, thank you.
No. You're so welcome. Welcome to our show.
Hi, thank you very much. Thanks for the invitation, and I'm happy to be here.
We're going to have some fun. And I asked Dr. Kurtin to be on this show because I went to one of his lectures. I guess it was about 2 weeks ago. He did a lecture on robotic surgery. I learned a lot. So I thought he could share that with our listening audience.
So when you trained, you didn't go in on any robotic cases?
Robotic cases, they just came out with CT scans.
I trained recently enough to I actually think I saw you in the OR.
Yeah, but you didn't see any robotic cases.
I think I did.
Yeah, maybe.
Because those are notoriously some of the more boring ones to stand by because everything is so perfectly contained and safe. And
everything's a matter of perspective when you're in the operating room.
When you're the one doing it, it may not seem so safe.
Exactly. Well, safe, but it seems much more exciting when you're doing the operation versus observing.
Dr. Adam Kurtin, what brought you to the Stuart Port St. Lucie area?
Well, that's a good question, Ira. I came back in 2000. I was born in Manhattan and grew up in New York, in Jersey, and schooled in Jersey, trained in Jersey, and I met my now wife. Actually, she was my medical student when I was a resident. She is a native Floridian, and she said to me, "Don't you want to live where people vacation?" And I said, "Yeah, that makes sense."
The ORs are all alike. I don't think.
Right. I know. Maybe it's not for me. But
and you're one of the hardest workers I know. But I know
Thanks.
you have a lot of hobbies. One of your hobbies is saltwater fishing.
Right.
And I know every free moment you have, you're out there fishing.
Pretty much. I mean, that was the other way she got me here is actually, I didn't saltwater fish when I lived in Jersey. She hooked me up with her brother, who is a big game fisherman and goes to the Bahamas all the time. And I got my first taste of real saltwater fishing and lobstering through him. And she did that to get me to come here.
So now you're a Floridian and you're here to stay?
Yeah, it's been 20 years, Ira. It's 20 years is a long time.
That has gone fast, hasn't it?
Really has. It's really, it's been a blink of an eye.
Now, you're part of a much larger group now. You're with the HCA medical system up in Port St. Lucie. Tell us a little bit about your practice.
Yeah, so I have three partners. Dr. Loyola has been in town forever, and I joined him. We were actually in private practice for about 10 years. 10 years into it, we decided to join HCA, and we were hired by St. Lucie Medical Center. Been there since I moved here, but now we're, I suppose, part of the Heart Institute and this wonderful large practice.
And your wife, where does she work and what does she do?
So Jennifer is a family doc, and she also is employed by HCA, and her practice is on Jensen Beach Boulevard, and she's with She's with Dr. Tobin, and very busy, very busy.
Now we ask all the married doctors who come on the show, and there seems to be a lot of married doctors that come on this show.
I would say the overwhelming majority.
What their dinner conversation is like? Is it all doctor talk, or do you leave that at the office?
Well, we try not to talk doctor talk at home, but it always devolves into something about, oh, I saw this patient today. I saw this,
You have mutual patients?
We try not to, and she doesn't refer me patients directly. I think it's a conflict of interest. So there are certain patients that are hers that go through other specialties, gastroenterologists, who will refer them to see me, or endocrinologists.
But unlike most surgeons, and this is why I refer Dr. Kurtin a lot of cases, he has surgical hands and surgical skills, but he kind of has like us, concierge doctor mentality. He spends time with his patients. His patients adore him. He explains things well. He's available. He's concerned. And his follow-up is spectacular. And I like that about him.
Yeah.
Thank you.
Sure.
Thank you very much, Ira. I mean, I think we're all a function of how we were trained. And I think that I was very blessed to be trained by the men who instilled those ideas in me.
So we talked about you and Jennifer, and you're having dinner, and I'm sure your kids roll their eyes. Oh my gosh, here they go again, talking more medicine. But you have three kids?
Four.
Yeah,
four.
Yeah. When do you find time? How do you balance it all out?
Well, I used to take them all fishing with me, and they were very interested for the first few years, and then they get tired of getting yelled at on the boat, and then they're done with that. So they're all burnt out on fishing. Three are out of the house now. We're left with one in high school, and it's great to see them spread their wings and fly.
And what are their aspirations? Is medicine in the picture?
Interesting. One daughter is moved, and she's working on a PhD in neuroscience in London. And my other son is now teaching in Costa Rica. And my other daughter's up at FSU, and she wants to be a baker. My littlest guy is here in Jensen Beach High School.
Wow. That's nice.
Yeah, very nice.
So, as a general surgeon, and if you've just joined us, we're talking to Adam Kurtin, surgeon, HCA Medical Center. And in just a little bit, we're going to talk about the newer advances in robotic surgery. But overall, what types of surgery do you do as a general surgeon?
Well, Ira, the specialty of general surgery is quite broad, and it's the best thing about my job is that I get to do such a variety of procedures. I deal with everything from the neck, thyroids and parathyroid disease, to dealing with breast cancer or even benign breast disease, a lot of biopsies, and fortunately, a lot of breast conservation therapy so that we are not performing as many mastectomies as were done in the past. We do everything in the abdomen, pretty much everything, abdominal surgery from gallbladders and hernias to stomach cancers, colon cancers, hernias, to soft tissue surgery. I mean, it's just every day. It's you never know what you're going to get.
And has that changed? I mean, have the diagnoses changed? Are people getting the same types of surgery and the same amounts that they did when you were in training?
It's interesting that a lot of the abdominal surgery we did open when I trained then evolved into laparoscopic surgery, using a camera and skinny instruments through, quote, keyholes. Now, over the past couple of years, we've taken it to the next level where we're doing robotic surgery. So robotic surgery is like laparoscopy in terms of minimal access, small incisions, but it's enhanced even further with these new, very dexterous techniques.
Dr. Leanne, Dr. Kurtin has operated on my family members.
I love it when that happens.
I love it when that happens too.
You can give a resounding.
I can give
you
him.
You can say that you trust him with your family.
I trust him with my family's lives. My dad had elevated calcium for years, and his doctors where he lived didn't figure it out. And Dr. Kurtin said, I think your dad probably has hyperparathyroidism. The parathyroid glands are small glands. Sometimes you have 4 of them, sometimes you have 6 of them, but they're on either side of the thyroid gland. And they regulate,
which is in your neck,
which
for
is in
those
your
of you that
neck,
don't
for
know.
those that don't know. And the parathyroid glands regulate calcium metabolism. And so if you have an overactive parathyroid gland, and they're very small and very hard to find, but this is kind of what will happen is you'll develop osteoporosis and kidney stones. And my dad had both osteoporosis and kidney stones because his calcium was being leached out of the bone because of his overactive parathyroid glands. And Dr. Kurtin, this is one of his little niches where you can do anything as a general surgeon, pretty much. What prompted your interest in the parathyroid glands?
Well, when I trained up in New Jersey, I was fortunate to train under like 40 different surgeons. And one of those guys had a particular interest in thyroid and parathyroid surgery. And I just found those operations were kind of neat. And as I finished training, went into practice, I saw that there was a big need, especially when I moved down to Stewart, Port St. Lucie. I found there were a lot of patients with hyperparathyroidism that was not appropriately surgically treated. And these patients were being told that, well, we don't do anything about this. So when I came to town and I found this, I started telling primary care doctors that, hey, I can fix this. And, it was a nice little niche I developed. And the best thing about parathyroid surgery is nowadays we get immediate feedback that the disease is cured. The parathyroids make this hormone, parathyroid hormone, that you can measure in the bloodstream. And that hormone has an incredibly short half-life. In other words, after 10 minutes, it disappears. So if I can find a tumor of the parathyroid that's making too much hormone and a patient's blood levels are super high, as soon as I remove it, if I check their blood levels, their parathyroid hormone level is boom, down to normal. And I get immediate feedback that patient's cured.
Now, I know you have a unique way of locating the hot gland, so to speak, and a way to remove it without disfiguring the neck. Can you tell our listeners a little bit about how you go about doing that?
Yeah, there's an approach called minimally invasive radio-guided parathyroidectomy. And some of these parathyroid tumors have this strange affinity for radioactive labeled technetium. So if a patient is injected with a radioactive substance, some of these growths will suck up that radioactivity. And I can use a handheld Geiger counter to locate it in the neck. That way I can make a much smaller incision and guide my dissection to that area where the radioactivity is and find the offending gland or tumor. A normal parathyroid is about the same shape and size as a lentil bean. They're tiny, they're 50 milligrams. And some of these parathyroid growths, even if they're, overactive, they're only about the size of a raisin, or if they get to be as big as cherries, but that's a big one. A cherry-sized adenoma is a big parathyroid growth.
And the recovery time from a procedure like that is just a day or so, right?
Yeah, well, I mean, if we do a radio-guided procedure, check the levels in the OR and they fall precipitously, those patients go home the same day. But if I explore the entire neck and I look on both sides, I'll keep a patient overnight just to watch them, and then they can go home the next day.
So for our listeners, can you describe, surgery one of the things that did not appeal to me to surgical specialties was the fact that it's difficult to plan your day, right? So, I mean, surgery can take, you think it may take 2 hours and it ends up lasting 4 hours. So I imagine that.
And the other thing is not planned. I mean, he has emergency cases coming
Totally.
throughout the day as well.
So I suppose you're really good at this at your stage of the game. So what does your day look like? I mean, what time do you get to work? What does a typical day look like?
That's a funny question, and I'm not trying to talk people into going into this line because it's pretty hard. It does take a lot of you better love it because you're going to spend a lot of time doing it. Every day is different. I'm in the office on Tuesdays and Thursdays. I'm sorry, Tuesdays and Fridays, and my full days in the OR are Wednesdays and Thursdays. I do outpatient surgeries on Mondays. But you know what I tell everybody? I tell the students and interns that rotate with me, we operate every day, So I have non-operative days. Today's a non-operative day. I did surgery this morning. Tomorrow I have a full day of office. I have surgery scheduled for lunch. So, you just got to do the job when the job is there to be done.
So with the extremely long hours, does that ever get to you?
I think the short answer is yes. I was on call this weekend. I rounded Friday, Saturday, Sunday. I'm working today, and I'm just sometimes you get tired, but I do notice the older you get, the more tired you get. When I was in my 30s, I could just operate day, night, and never bothered me. Now it takes a day to bounce back after operating all night.
So on a busy day, like how many cases might you do on an operating day?
On a big day, I could do 6 to 8 cases. 8 cases is not unheard of. And again, I do such a spectrum, a variety, that there are big cases and there are little cases. Some cases could take 3 to 4 hours. I'm not the kind of guy who's going to let grass grow under my feet in the OR. I get in, I get the job done, and I get out. Some things do take a long time, though.
And how many general surgeons work out of the hospital where you practice?
So right now we have 4, and I think our hospital, about 250 beds. I think 4 surgeons is a good number to support the needs there. But I've been there for, again, a lot of time, and there've been years we've only had 2 or 3. And we do what has to be done.
So what you're saying is that you have scheduled operating room cases, and then you have emergency cases. So these are people that come through the emergency department and have some sort of malady that requires an operation. How many times might that happen to you when you're on call? I mean, how many?
I would say 60% of the time, patients get bad gallbladders, appendicitis, diverticulitis, perforated ulcers, abscesses that need to be drained. Things happen, and we're the offensive linemen of the hospital. We're there for, we're the dirt lovers.
Adam Kurtin, what's your favorite procedure?
That's a great question. Right now, I could tell you the answer to that. It's a robot-assisted right colectomy. I just like using the robot to do advanced abdominal surgery. I would love to say robotic splenectomy. The problem with elective splenectomies is that they're few and far between. In our setting, we don't get enough referrals to remove spleens with the robot. It's just not a common procedure. But for now, right colon resection. Next, left colon resection.
So it's a flavor of the month.
Well,
You've had favorites. You've had other favorites in the past.
Laparoscopic sigmoid colon resection was my favorite operation before the robot. I really enjoyed doing laparoscopic left colons. That was a lot of fun. You learn to perfect certain techniques, even as you're an experienced surgeon. You've been out for a while. Things are changing. I didn't train doing laparoscopic colon work. And in practice, we developed, we learned the operation, and you perfect it over time, And it's a team sport. It's not just me. It's my scrub techs. It's my my assistants. And, it's a well choreographed procedure, dance. And with everybody working together, it can be a thing of beauty. And, we'll talk more about robotic surgery, but I mean, when I trained, open right hemicolectomy patient was in the hospital for 7 to 9 days routinely. And then we started doing them laparoscopically, and we thought we were really great that patients could go home after 5 days. And last week I did a robotic right colectomy on Thursday, and he went home less than 48 hours later, eating and moving his bowels, and no pain and minimal narcotics, minimal or no postoperative narcotics. So it's been a huge advance, and it really has me kind of jazzed and excited.
What our listeners don't know, Leanne, is that the history of surgery parallels the history of war. Every major advance in surgery has come out of a war. Out of Vietnam came the trauma surgeons. Out of the Civil War came anesthesia. And with each new technique, there's been a war. Hopefully, it won't always be that way, but have you realized that?
Well, I want to tell you something very interesting that I don't think you realize. Robotic surgery was really initiated to treat patients injured on the front lines. Soldiers would get blown up and really damaged, and they couldn't get them back to the hospitals fast enough. So the thought process was to have these mobile units that would go out on the front line, bring this patient into this car vehicle, and have a robot there with a surgeon remotely operating on them, to get to them during that golden hour initial period. So that's where the development of robotic surgery came from too.
And I would imagine, and I heard one of the best lectures I ever heard was an astronaut who was a cardiologist, and he gave medical lectures to large groups. And he came to one of our Florida Academy of Family Physician meetings several years ago. And his big push was developing surgical procedures in space, because he said things are different. The blood, it's not in the body. You open up the body or you do a procedure, the blood is floating around. So it's hard to contain things when there's no gravity. And the other point that he made was that everyone in space, because there is no gravity, goes into heart failure. So these patients are in these astronauts are in huge doses of diuretics the entire time to keep them out of heart failure. Anyway, if you've just joined us, we're talking to Adam Kurtin, surgeon, right here in WSTU 1450. And in just a minute, we're going to talk about robotics. But I want to ask you one more question before we get there. And that question is, when you decided to do robotic surgery, and this is going to be our lead in for the next segment right before the break, were you a little resistant to it at first?
I think you must know the answer to that.
I did. That's why I asked the question.
Yeah, I was a big opponent to robotic surgery, and I just didn't see a need for it. We were very slick laparoscopically. Why would we need to use a robot? It didn't make sense.
Same reason why we have the automobile now and not horses and carts.
So what happened? I mean, did you have to train? Did you have to go to training to learn how to use it? I mean, you could see that this was where things were headed and that you wanted to remain in practice. So you just had to bite the bullet and go?
Not really. I mean, there's still most surgeons don't use the robot to do general surgery. But you want to get to this before or after the break?
We can do this now.
Okay. So the story goes like this. Robotic surgery was done for prostatectomies and hysterectomies. It was great for one quadrant surgery. And us as general surgeons, we needed access to all quadrants of the abdomen. So the old robots really weren't great for us. I'm gonna have to.
Are
finish
you going to
this.
hold
I'm
that
gonna have
thought?
to finish
We're
this.
going
Yeah.
to take a break. We're going to take a commercial break. We'll be back in 1 minute.
Okay.
That's right. We'll see you soon.
Welcome back. You have joined us back with Paradox. I'm Dr. Leanne Talton here with my co-host, Dr. Ira Pearlstein, and we are talking to Dr. Adam Kurtin today about advances in robotic surgery. And before we went to break, you were just telling us kind of how things came to be.
So St. Lucie Medical Center decided that they were going to embark on a robotics program, and they were looking for a robotic guy to do the cases. And I had told them that I didn't see a need for the robot. I didn't understand why would anybody fix a hernia with a robot. I mean, our laparoscopic hernia operations, they were pretty slick and patients did very well. So we hired a young woman out of residency, and she had done some robotics in her training, and she stepped up and said, I'll be the robotic surgeon. So she went through some training, and she was about to do her first case at the hospital, and they brought down a proctor, an experienced surgeon from Orlando. And the night before her first case, we were invited to go out to dinner with this proctor, and his name's George Florin. He's a wonderful guy. And I went to dinner.
Give him a shout out.
Yeah, I did. Hey, George.
Okay.
I went to dinner. I went to dinner with George, and he had trained in Pittsburgh. He's a little older than I am, under Dr. Starzl, the guy who invented the liver transplant, and so he came from a very reputable program. And just talking to this gentleman, I realized this is the real deal. This guy's a real deal surgeon. And he told me that, he was kind of bored with surgery. He was at a point in his career after 25, 30 years where he was thinking about getting out. And his junior partner started doing robotics, and he picked it up and he was like, hey, this is really cool and fun. And then he started seeing the outcomes that he was having, and his patients were doing great. So it kind of made sense to me. And I said, let me give it a shot. George invited me to come watch him operate in Orlando. So I went up to Orlando to watch him do some cases, and that was it. I was hooked. I said, I got to train. So I went and I trained, and the rest is history.
So the analogy that I see is robotic surgery is to surgery like flying a drone is to being a pilot. You have to have very good manual dexterity, but you're not actually in front of the patient. How does that work?
Well, that's right. The difference is if you said it's like a pilot, right? Like flying a drone is like flying a plane. When you crash a drone, nobody gets hurt. If you crash a plane, someone
We
gets
get
hurt.
the graveyard behind you.
All right, it was
Okay.
a partial
Okay,
analogy.
so let me ask you this. So let's break it down nuts and bolts for people who don't even understand what laparoscopy is. Okay, so can you just imagine we're all sitting here looking at a belly, all right, and the patient has what? Pick your favorite.
Let's talk about a hernia.
Okay,
It's a common problem. Inguinal hernia, a lump that sticks out of your groin.
Okay.
So to do this robotically, we make 3 tiny little holes in your abdomen, usually just above the level of the belly button, and each hole is like a half an inch. And we put a camera through the middle port, through the middle hole, and we put 2 little instruments through the other 2 holes. And
so at this point, it looks like laparoscopy.
Well, I guess I didn't explain that.
Except for the 4th hole.
First we
with laparoscopic surgery, I think it's 4 holes, right?
Well, it depends on the procedure. For a hernia, there's 3, but for gallbladders, it's 4, and even robotically with gallbladders, we use 4 holes. But what we didn't tell the listeners is that first you have to inflate the abdomen with gas so that there's room inside. There's a space. So we blow the abdomen up to look like a dome so that we have room to put a camera in and little instruments through these tiny little incisions.
And that gas is CO2, carbon dioxide?
Absolutely, okay. Yeah. So then once I have the camera and instruments through these little holes, we bring the robot over to the patient, and the robot connects up to these instruments. I then take my gown and gloves off, and I sit down at a console. It's like a cart that has a viewfinder in it, and I have a nice comfortable chair, and I put my head into this console, and now I'm looking 10 times magnified, ultra high definition, 3D inside someone's abdomen. So the visualization is incredibly higher def than laparoscopy. When we do laparoscopic surgery, I'm looking at a TV screen. It's flat, it's 2D, and they made some high def screens, but I'll tell you, in the early days, it looked like those rabbit ear, snowy images. Now I'm immersed inside someone's abdomen. I can see every capillary, every nerve. And so I can see things that we never saw before. And that makes you a much better surgeon.
So you don't have to say sponge or anything like that.
Well, it's interesting. Once in a while, you have to have your assistant change instruments. If I have doing a robot colon resection, I have a camera and I have 3 ports, and I control these 3 different arms at this console. I have little controllers that my fingertips are in, and the motions of my fingertips are translated to the motions of the instruments inside the abdomen.
So you are in the console, but who else is in the room where the patient is?
It's a great question. So at the table, I have an assistant, and I also have a scrub tech. And the console has a microphone, and the robot at the table, at the patient's side, has speakers and a microphone for them to communicate to me. So we communicate back and forth, and I'll say, in arm 4, change the scissors to a grasper, and whoosh, scissors come out, whoosh, grasper goes in.
Do they get to watch as well? I mean, is there a screen in there so that your assistants can see everything that you see the way you see it?
Well, everybody in the room's watching TV screens. There's 2D monitors and they're high def monitors. Everybody else is watching, but I'm the only one who sees in 3D.
Now, how far away is the console from the operating room table? Are we talking like maybe 1.5 feet? We talking about clear across the room? Because those operating suites are pretty good size.
Yeah. I'm in the corner of the room. I'm about, let's say, 12 feet away from the patient. You can do remote surgery, and it's feasible to have the surgeon's console in a completely other room as the patient cart. But we're in the same room. I'm just away. There have been cases done transatlantic, and the speed of the information of the surgeon's motion at his console translated to the instruments inside the patient is milliseconds.
Even transatlantically?
Yeah, there's ways that data can be transmitted that fast.
So the anesthesiologist feels left out of all this. He's still at the head of the table pumping gas or running the ventilator at this point. Do you think they feel left out?
Well, they're always left out. Every anesthesiologist.
We need to have an anesthesiologist on the show and give them rebuttal.
Every anesthesiologist wanted to be a surgeon at some point, and they decided they didn't want to work that hard, so they went into anesthesia. It's true.
Well, I had an anesthesiologist once tell me when he described his profession to me that he had hours of boredom and moments of terror. Yeah. And that's the description of what an anesthesiologist does. Because when they have to act immediately. But most of the time, they can just sit back kind of on autopilot.
True.
So let me ask you this. Okay, so what surgeries right now are you doing robotically?
Okay, that's an excellent question. The most common operations I'm doing first of all, I'm doing pretty much everything in the abdomen now robotically.
So name some of those operations for our listeners.
Gallbladders, cholecystectomy, hernias, inguinal hernias, ventral hernias, incisional hernias. We're implanting meshes. Instead of putting mesh in with tacking devices, painful tacks, now we're suturing meshes in, because with the robot, our instruments are articulated. We have so many more degrees of freedom of motion with our instruments inside the abdomen. It provides a whole new opportunity to sew inside. So sewing laparoscopically is possible. It's just much more difficult than sewing with the robot.
So you've got 10 times visualization. You're looking at it in a 3-dimensional image. How much less blood loss is there?
Significantly less blood loss.
And why? Why?
Because I can see every vessel. Okay. So I see every little vessel, and it allows me the opportunity to coagulate, cauterize every little bleeder before it turns into, a bleeding vessel. Let me finish more procedures we do. So right now, at St. Lucie Medical Center, I've done gastrectomies, splenectomies, and my real major case that I'm doing colon resections robotically. And I'm doing almost every colon resection I can for colon cancers, for recurrent diverticulitis, for large polyps that the GI doctors can't remove with the scope. We're taking out these colons using the robot. And again, we're going from lengths of stays of 5 to 7 to more days down to 2 to 3 days.
So less overall time in the hospital, better healing, less pain because no tacking. You're doing some suturing in there. Does a procedure take longer to do robotically than, say, laparoscopically or open?
There's a lot of variables that go into how long an operation takes. And some of them are a little longer, but if a patient is going to get out of the hospital in 3 or 2 days versus 5 or 7 days, I'll spend an extra hour in the OR. Now, that being said, I've been at this almost 2 years now. We've done 230 cases or so, and my operative times have really dramatically reduced.
How expensive are these robots?
That's a good question. There are
We only ask good questions.
Well, the robot themselves, the capital expenditure is significant, but once you own the robot, as the hospitals do, the cost per procedure is actually less. And when you look at the overall cost of, say, a colon resection done open, laparoscopic, or robotically, there's data out there that show that a robotic colon resection overall is much less expensive than an open case. Realize an open case is going to be in the hospital for about 7 days, and a robotic case can be home in 2 days.
And how many robots does St. Lucie Medical Center have?
Now we have 2 of Da Vinci, Intuitive Da Vinci's latest and greatest. It's a model called the XI.
So you said we're doing almost everything in the abdomen robotically. Are there other places in the body that we can do robotic surgery on?
Not commonly at this point. And there are some surgeons, the Intuitive Corporation does not approve, and the FDA has not approved robotic mastectomies, but it's been done. Again, I'm still at that point where I don't even see why you would do that. There are places, again, the FDA hasn't approved it and Intuitive Surgical doesn't approve it, but robotic thyroid surgery is being done through the armpit. So there's no incision on the neck. And, as you know, in certain Asian countries, I think in Korea, there's a lot of stigma attached to a female with a neck scar. So I think Korean surgeons developed these techniques of going through the armpit, the axilla, to get the thyroid out.
Who knew?
Well,
he knew.
Incredible.
Kurtin
Well,
knew.
I was thinking about trying that because I do a lot of thyroids, and I was thinking about, but how can you take a 45-minute operation and now make a 6-hour operation out of it? Well, to spare a incision that's usually very well healing and almost invisible most of the time.
But you would get better visualization and probably less chance of nerve damage that would possibly nick the recurrent laryngeal nerve, I would imagine.
I don't know. I can't
So you won't lose your
imagine.
voice.
I can't imagine. Again, I'm not as close-minded as I used to be. I used to be very dogmatic about things. I was opponent of the robot. Now all I want to do is robotic surgery. So, right now I don't see doing a thyroid through the armpit, but maybe someday.
We didn't. Yeah. Now we're putting in valves through the arms.
Do you
so
think
we can do anything?
Do you think your
Crazy.
kids, perhaps, or surgeons coming up in the future, because they've grown up with video games, have better manual dexterity, and therefore the robot would be almost intuitive to them? Oh, that's the name of the company.
Interesting.
But so, thoughts?
I think that technology is advancing exponentially. I think that in my career, I've seen incredible improvement in the approach to certain operations. And I think that as this technology becomes even more streamlined, I think there'll be more limited access. In other words, smaller incisions, better instrumentation to do what we have to do inside the abdomen. Beyond this, I think surgery for certain diseases is going to go away. I think, molecular genetics is going to totally change oncology care. I don't think we're going to be cutting out certain cancers. I think we're going to be treating them with certain gene therapy to make them just melt away. And, there's so much that's coming down the pipe that I can't even imagine.
So are there any disadvantages to robotic surgery? I suppose it's on a case-by-case basis, but if you could generalize.
Yeah, generalize, no.
He
Listen,
loves it, folks.
I got to tell you something else. I stood at an operating room table for the past 27 years, in training and practice. And there are certain specialties that would sit at an operating room table, like hand surgeons and certain ear, nose, and throat procedures.
Ophthalmologists.
Right, they sit. And I'm not going to say that I thought you had to stand when you did surgery, otherwise you're a sissy. I wouldn't say that ever.
But you wouldn't say it out loud.
But you just did.
Right, right, right.
To
Okay, you
thousands of
thought
people
it. You
on the
thought it a
radio.
few times.
And we do
Anyway.
have other surgeons listening to this show.
Again, I've changed a lot. I sit now, I sit at a console, and I think that ergonomically, I have less back pain, less shoulder pain, less neck pain that I did. And I think that robotic surgery will also increase the length of time surgeons will be able to practice. I think, standing at a table, hunched over and twisted to do a laparoscopic operation is ergonomically very unfriendly.
And I think there's data that says that surgery is one of those specialties where the longer you've been doing it, the better you are.
I think so.
Do you think it's less stressful to sit down in front of a console and operate?
As long as everything's going well, I'd say yes. I haven't been in a situation where I've had to, rapidly enter an abdomen for a problem. But I could imagine that would be stressful if and when that ever occurs.
So you said there hasn't been a time where you've had to abort the robotic procedure to go towards an open procedure?
Not yet. Not to date. And I won't say that'll never happen. You do enough surgery, you're going to see enough complications.
We can knock wood, but we don't have wood, and we don't like to knock on the table because the sound engineer gets mad at me when I tap on the table.
So where do you see this going in the future? I mean, you mentioned some of the ways that you think, people are obviously tackling different areas of the body that you wouldn't suspect, but I mean, where else do you think this could lead?
So I think that the next greatest advancement in surgery is going to be enhanced visualization. I think that when I look into the robotic console now, the next generations of robots are going to have image overlays of CAT scans and MRIs. So with a press of a button, I'll be looking at the anatomy inside a person, but then I'll be able to press a button and see, all the blood vessels that are under the tissues and organs. And if there's a tumor there, I'll press a button and I'll be able to see, the relationship of this tumor to, say, the ureter that drains urine from the kidney to the bladder. And it'll allow me to operate and see things that are not visible with the naked eye, and it'll really take the game up another notch.
And how far away are we from actually seeing that become real?
Well, some of that exists already. So, when I do colon surgery, we have the ability to have a urologist stick stents up into the ureters, and we have a substance, fluorescing dye, that you can inject into these stents. And now when I'm at the robotic console, I can press a button, and now instead of seeing through visible light, I'm looking through black light, and the ureters will just glow. So, the robot has a lot of neat, what do you call it with cars? Neat options. And so there's like little buttons I press and the ureters will glow. Or we have anesthesia inject patients that we're taking their gallbladders out with this fluorescent dye, and their bile ducts light up. So I'm looking at a gallbladder, I lift it up, I press a button. Now I'm looking through black light and I can see where the common bile duct is, the common hepatic duct. It's not visible under visible light, but I can see these structures because of, so it exists now, and the next generations of this is really going to take us to a.
So for our listeners that didn't know, and exploring the common bile duct is very difficult. You don't want to ever nick the common bile duct. You don't want to cut it, destroy it. But sometimes there's a stone that's stuck in there. And after the gallbladder is removed, they would bring in equipment and they would do what's called an intraoperative cholangiogram, where they would actually do a dye study right in the OR. So this is kind of like an all-in-one.
Kind of, you can see things with a cholangiogram that you can't see using this fluorescing dye. And we still do cholangiograms when we have to, but the fluorescing dye is helpful to visualize the location of the ducts and keep them safe.
Now, I know you're not a vascular surgeon, but what vascular procedures are being done by robots?
I'm not aware of any robotic vascular surgery, except for, when they made the robots, we talked about wartime, but they also created the robot for coronary bypass surgery. So, if a surgeon has a tremor, the controllers that a surgeon has are translated to the motions at the tips of the instruments that are operating. And you can, in essence, eliminate any tremor that a surgeon might have. So for fine coronary artery bypassing, that was felt to make it a better instrument for these really fine movements. I don't think it took off greatly, but I know that there is a lot of hepatobiliary surgery being done with the robot. They're doing robotic esophagectomies, robotic liver resections, robotic pancreatectomies. So pretty much everything is possible to do with the robot. The vascular world, their minimally invasive approach is going through the vessels now. This world of endovascular surgery where they're putting wires inside of the vessels, ballooning things open, putting stents on the inside, and instead of doing external surgery, doing internal surgery.
So one of the things you talked about made me think about AI, because you're really touching or dancing around the AI thing. Is it possible that AI could be taking away some of the decision making?
I think so. I think I joke around that the robots are gathering data on every operation we're doing, and what the robots are doing. This is, as I'm guessing that this is happening, is looking at every variation of the anatomy, every variation of the dissection, and storing this in some big server somewhere so that someday the robots will put us out of business.
Kind of like Tesla, right?
Maybe.
Yeah.
Well, it's interesting. I'm interested to see what neurosurgeons are going to use robots for. I was impressed when they were doing TAVRs, not having to open people up to do valve replacement
In the heart.
They can just and heart procedures with actually going through the arm or through the leg. We've got so much cool stuff. You have been an amazing guest. You worked all day.
All weekend, I think.
You're in the OR. Not tomorrow. What's today?
Tomorrow.
You are
in
in the
office and OR.
office.
Yeah.
Whatever
Anyway.
happens. I mean,
Yeah.
you're a general surgeon. That's your life.
Anyway, I've enjoyed this tremendously. Thank you guys for
It's
having
been
me.
so fun.
Thank you.
Thank you. Tune in next week to another episode of Paradox. For myself and Dr. Talton, have a great week.